Welcome to another presentation where I'm going to dive into hypercoagulation, which is another very common root cause of bladder pain syndrome that I'm finding in my clinic. And I have to thank Ruth Kriz for bringing this to my attention. And I decided to dive deeper and to take this into more of a nutritional approach as well to see how the nutritional interventions could help modify some of these risk factors. Please take a moment to review this disclaimer. So recently it has come to my attention that there's a strong connection to fibrin, hypercoagulation, biofilms, and the embedded infection associated with IC and bladder pain syndrome, and even chronic UTIs. It's a complex interaction of genetics and environmental influences that leads to this condition. And one very strong environmental influence are infections, and especially viruses. So I want to dive into that a bit today. But before we continue, we have to become familiar with some very important terms to understand this presentation better. So what is coagulation? It's the process in which a blood clot forms. It's often referred to as secondary hemostasis. Now we have fibrin. This stabilizes blood clots and promotes this hemostasis. Fibrinogen is a glycoprotein found in the blood, and it's converted to fibrin, and it contributes to inflammation, thrombosis, and wound healing and blood clots. We have thrombin, also known as factor 2A, which enzymatically converts and catalyzes the conversion of fibrinogen to fibrin. Factor 5 is a protein that acts as a cofactor activated by thrombin, and it can convert prothrombin to thrombin, acting to increase coagulation. Now we have something known as protein C that degrades and stops its activity. Here's an important one. Plasminogen activator inhibitor 1, PAI1. It inhibits plasminogen by terminating the activity of something known as TPA, which I'll talk about later, and it causes the procoagulation state this way. It basically inhibits fibrinolysis. Now, the reason why this one's important is because there's a lot of people who have mutations on this particular enzyme or factor. Tissue factor is basically through the action of cytokines. It promotes prothrombin and blood clotting. We have endotoxins, which are, they tend to stimulate PAI, and TNF-alpha particularly can promote a procoagulant state. So they stimulate tissue factor. We have NOS2, inducible nitric oxide, and this can often be elevated in infections and inflammation and can activate platelets. It can, we call this iNOS. It can play a role in platelet activation that can then generate thrombosis as well. Now, iNOS is dependent. There's an iNOS-dependent nitric oxide production in the platelets that's induced by thrombin. Homocysteine is an amino acid made by methionine in the methylation cycle. It can increase platelet activation, encourage blood clotting, and raise your risk of coronary artery disease, heart attacks, and blood clots and strokes. Platelet activation, again, through the activation of cytokines and endotoxins, can activate platelets and can activate many coagulation pathways. So why is this? Because activate platelets can secrete coagulation factors and support thrombin and fibrin formation. And finally, Lp(a) binds up TPA, which I said we'll talk about. It's basically tissue plasminogen activator, so high levels can reduce plasminogen and increase blood clotting. Now, to understand coagulation, you have to also understand anticoagulation. It's basically the process of slowing down or hindering the process of making clots. So here are some components. We have plasminogen, which is a proenzyme that forms plasmin during the process of fibrinolysis. Now we'll skip down to fibrinolysis. That's the process that breaks down fibrin blood clots. Plasmin is a fibrinolytic enzyme that breaks down the crosslinks between fibrin molecules, so they're both important. Tissue plasminogen activator, I said that's TPA. That's involved in dissolution of blood clots. and its primary function includes catalyzing the conversion of plasminogen to plasmin, which is the main enzyme involved in dissolving blood clots. Antithrombin is a glycoprotein that inhibits the blood clotting pathway. It's basically an anticoagulant, and is among the number of regulatory mechanisms of this cascade, which provides a counter mechanism for clots and actually serves as 80% of the inhibitory component to thrombin. Protein C, another really important and principal inhibitor of coagulation because it degrades factor V. Protein S is a vitamin K-dependent protease that circulates in plasma at low concentrations and serves a critical role in the regulation of coagulation, also an anticoagulant protein. And then tissue factor inhibitor, TFPI, is basically we have tissue factor and then pathway inhibitor together. And it's an anticoagulant protein that inhibits early phases of the coagulant response. Inflammation has to come up here because it's really important to understand. And it's the central theme to the pathology of what could be going on that's upregulating this coagulation pathway. It's basically an event preserved from evolution, from the first multicellular precursor organisms to humans. And its main role is to defend tissues from insulting agents, mainly microbes, or direct damage as well. And it can help bring the host, which is you, back to homeostasis. And if it's not stopped, it can lead to serious consequences. This is the problem. So infections, chemical toxins, mechanical injuries, other things that can cause inflammation is a natural defense. But for example, if it's bacteria and they invade you, the organism, then your cells are driven to secrete pro-inflammatory cytokines. And this can also happen with, harmful toxins, radiation, microbial infections. I said inflammation occurs as a natural defense. And when it becomes dysregulated, this is the problem, it can cause harm to nearby tissues and induce a bunch of diseases. So we're looking at things like IL-1 beta, IL-6, TNF-alpha are 3 really major pro-inflammatory cytokines during inflammation. So we do have something else called COX-2. It's the rate-limiting enzyme for converting arachidonic acid to other pro-inflammatory prostaglandins and does play a role in chronic inflammation as well. This is why we talk a lot about fish and fish oil when we have nutrition talks. So when you're inflamed, what do you feel? Pain is the main one. Sometimes redness, heat. It does involve your immune cells, B and T lymphocytes, monocytes, macrophages, neutrophils, basophils, mast cells, dendritic cells. The response depends on the stimulus. So, depending on what's triggering it, the response will vary. But the first signs of inflammation are vasodilation and changes in vessel permeability, and they promote and permit the recruitment of cells in the inflammatory response. However, the key is chronic and uncontrolled inflammation plays a role in a variety of diseases, and we're talking cardiovascular, metabolic syndrome, and neurological. So this is where natural remedies can really be important because taking anti-inflammatory pharmaceuticals have a lot of side effects. So again, fibrinogen is a complex glycoprotein in your blood, and it's converted to fibrin, which stabilizes blood clots and promotes this hemostasis or blood clotting. Now, fibrin structure has mechanical properties that are modified by genetic and environmental influences or factors. Fibrinogen or fibrin, they kind of clump them together, also contribute to thrombosis, inflammation, and wound healing. So during coagulation, fibrinogen converts to fibrin. This is induced by thrombin, so it mediates it, and it promotes these fibrils that mature into fibers that promote really remarkable biochemical and mechanical stability to clots. So the stability is regulated by genetics, biochemistry, environments, and it just creates this dynamic kinetics of fibrin formation. And the interaction between fibrinogen and fibrin and other proteins, let's say, on the platelets, on the white blood cells, on your endothelial cells, are also involved. And this is involved in a lot of situations. So obviously, blood clotting, thrombosis, even pregnancy, inflammation, infections, cancer, and other states. So disorders in fibrinogen concentration can increase the risk of bleeding, thrombosis, and infections, and of course, blood clots. So plasminogen activator inhibitor 1 is the inhibitor of plasminogen, and it terminates the catalytic activity of TPA by binding to it, and the liver is also involved. It's removed from circulation by the liver. But the biggest thing to understand is it strongly inhibits fibrinolysis, causing a procoagulant situation. And it is cytokine mediated, such as TNF alpha and IL-1, because it decreases the free TPA and increases PAI-1 production. So basically TNF alpha, which a lot of my patients have mutations on as well, can increase this process. Just the key point to get here is inflammatory cytokines can increase this production. That increases coagulation. So being inflamed is a big risk factor. Things like endotoxins from gut bacteria can stimulate, as well as TNF alpha, whether it's, caused by various different chemicals and food and leaky gut or genetics. It just stimulates this activity and puts you in a procoagulant state. And this was shown with a rise in fibrin breakdown documents as seen. So they've actually seen this in some animal models, which is kind of interesting. So high circulating levels of PAI-1 can impair the endogenous thrombolysis, and this is the principal inhibitor of plasminogen activation. Factor V is another protein of the coagulation system. It is actually functions like a cofactor, and the synthesis occurs in the liver. Thrombin activates it, converting it to, what it does, it converts prothrombin into thrombin, and activate protein C degrades it, and thrombin activates protein C to decrease clotting. So deficiency of factor V can increase the risk of hemorrhage. So we have two things going on here. We have the risk of blood clots, but then you also need these other factors to prevent you from bleeding out. Some people do have mutations, and the most common is Leiden factor V, which does predispose people to more thrombosis. I should have said in the other slide that I don't see a lot of Leiden factor V mutations. That's not the most common one I see. I mostly see the PAI-1 mutations when I do testing. So endothelial cells are also important because they play a role in the mechanism that contributes to inflammation and induce activation of coagulation. They respond to cytokines that are expressed and released by activated white blood cells, and they can also release cytokines themselves and are able to express adhesion molecules and growth factors, basically molecules that promote inflammation and affect the coagulation response. Endothelial cells can interfere directly with the initiation and regulation of fibrin. So inflammation-induced coagulation activation is categorized by widespread intravascular fibrin deposition, which appears to be a result of enhanced fibrin formation and impaired fibrin degradation. So there's a lot going on here, but the key here is to understand that inflammation can induce this pathway. Tissue factor, a protein expressed on several cells throughout the body. Usually not in direct contact with the blood though, and there's a lot of activations involved. But the key here is tissue factor is induced in the action of things like cytokines, C-reactive protein, and advanced glycosylated end products, which I talk a lot about in my meetings related to diet, because you can have a diet that has a lot of these and it can promote inflammation. It is stimulated by your platelets as a result of another inflammatory cytokine called NF-kappa beta and other cytokines such as IL-1 beta, TNF alpha, and IL-8. Now the good news is the body has several mechanisms that counteract the systemic activation of coagulation that occurs upon inflammation. So we are born with the ability to do that. These are called coagulation inhibitors, and they are there to slow down the process, but some people are either just very inflamed and then there's pro-inflammatory state that's just pumping out all of these things, or maybe they have genetic defects. So platelets become really important because they play a role in inflammation-induced coagulation activation. For example, endotoxins can actually activate platelets directly. Cytokines can also induce platelet activation, and I have to also mention INOS, inducible nitric oxide, which some people have mutations on as an upregulation, can induce that. In fact, there's some thought that INOS was responsible for some of the platelet activation during COVID. So if the infection is very severe, through the process of platelets, we can get this coagulation pathway activated. Antithrombin inhibits the clotting process in coagulation, so it's anticoagulant. And it does serve as 80% of the inhibitory component to thrombin formation. Deficiency is linked to increased risk of thrombosis, but even thromboembolism and other associated complications with being hypercoagulable. And it does inhibit coagulation proteases by a 1-to-1 complex formation. Plasminogen is a proenzyme, and it is cleaved to form plasmin in a process known as fibrinolysis. So this is a good thing. It's part of the pathway that breaks down the blood clots. It is plasmin is an endogenous fibrinolytic enzyme. Like I said earlier, it breaks the crosslinks between these fibrin molecules, which basically are the structural components of blood clots. But its activity is very short-lived. And it's only activated when the clot is no longer needed. So the body is very smart and understands when you need a clot and when you don't, usually. Tissue plasminogen activation, talked about this several times. It is a serine protease, so it cleaves peptide bonds in proteins and is an essential component of the dissolution of blood clots, catalyzing the conversion of plasminogen to plasmin. Basically activates plasminogen. So what TPA does, it attaches the fibrin on the clot surface, activates the fibrin-bound plasminogen. The plasmin is cleaved from plasminogen that's afflicted with this fibrin and breaks up the fibrin molecule, and the clot dissolves. So you can kind of imagine it's similar to like dish detergent and how it breaks up fat molecules. Protein S is a vitamin K dependent protease, an anticoagulant protein. Deficiency can result in increased blood clots, and you can have an autosomal mutation, a dominant mutation actually, but even a single copy can cause a mild mutation. Double copy can cause severe, and this is vitamin K dependent. So if someone has vitamin K deficiency, it can affect the activity, liver disease, acute thrombosis, medications that impair vitamin K metabolism, such as blood thinners, and pregnancy. So infections can trigger inflammation, which can trigger fibrin. This is a really important concept to understand. Inflammation can lead to the activation of the coagulation system, and cytokines that are generally activated when you're infected can play a role in the activation of coagulation and fibrin, and the impaired removal or impaired fibrinolytic system contribute greatly to the deposition of fibrin. Let's talk about endotoxemia. It is involved when there is a flood of endotoxins, which are a major component of the outer membrane of gram-negative bacteria, but also major contributors of inflammation. There's something called metabolic endotoxemia, and it's often attributed to overloading on high-fat meals. These lipopolysaccharides can stimulate the uptake of these LDL molecules. So these are the low-density lipoproteins and can reduce the efflux of cholesterol from foam cells. As a result, it can induce vascular inflammation by directly producing inflammatory cytokines from the immune cells. And the increased production of cytokines can promote oxidative stress, then leading to oxidized LDL, which increases the risk of hypertension via nitric oxide synthase inhibition. So this is where we have different mucous membranes where LPS can originate from, skin, mucous membranes, or other sites of bacterial infection, but the gut microbiota is considered the main natural reservoir of pro-inflammatory endotoxins in the body. So again, to repeat, the gut bacteria is where a lot of this originates from. So if you have dysbiosis, you're likely to be dealing with endotoxemia. There's some studies that had indicated that LPS levels increase following ingestion of a really high fat diet, probably something like McDonald's and fries. And gut dysbiosis can disturb the barrier, leading to the leakage of these metabolites such as LPS, and that's what really triggers the systemic inflammation in the body. So people don't have to understand a lot of systemic inflammation originates from the potential for when you have dysbiosis and you have this LPS, it can actually go through a leaky gut and enter into the bloodstream. And then there's a whole host of issues with vascular inflammation that are often triggered as a result. So not all dietary interventions lead to increased metabolic endotoxemia. Data from animal studies have suggested that dietary fats act as the main macronutrient responsible for postprandial endotoxemia, but the quantity and quality matters. So there's a study by McFarlane that determined or evaluated that a consumption of a single high-fat, high-calorie meal was associated with an increase in serum endotoxin, triglycerides, metabolic biomarkers, inflammatory cytokines, endothelial microparticles, and monocyte adhesion. So basically, in a nutshell, a lot of different processes that's going to promote inflammation and then coagulation in the body. Healthy diets rich in unsaturated fatty acids are associated with lower LPS. So it's not necessarily the good fats, it's the bad fats. High energy, high saturated fat diets, again, are associated with increased postprandial levels of LPS, increasing circulating levels of pro-inflammatory markers. Circulating levels of LPS can contribute to advanced aging. Endotoxins and TNF-alpha can stimulate this PAI1, which we talked about earlier, and can stimulate cytokines that can stimulate tissue factor promoting coagulation. So endotoxins alone can be a big trigger to some of these problems that we're seeing with hypercoagulation. Now back to aging, LPS is detrimental for healthy aging because elevated levels have been associated with a large range of diseases such as obesity, type 2 diabetes, coronary artery disease, and depression. So endotoxins stimulate TNF-alpha, which stimulate PAI1, and this is, the main point here. TNF-alpha and IL-6 are important for inducing fibrinolytic and procoagulant changes. There's another cytokine, though, I have to talk about, IL-6, interleukin-6. Very, very common. A lot of mutations in this one I see a lot, too. It is an important mediator of procoagulation, and then TNF-alpha, which I mentioned before, is involved in fibrinolytic response to endotoxins, and so any mutations in these cytokines can be detrimental as well. And I have to be honest, I do see people who have mutations when we run nutrigenomic testing on them. So again, tissue factor is synthesized in cytokines like these, TNF-alpha, IL-6, but also IL-1 can trigger this and stimulate this coagulation pathway. Mast cell activation, hot topic here. Mast cells are basically immune cells that are involved in our adaptive and innate immune system and have been referred to as the key effector cells of allergic diseases. You might be familiar with things like allergic rhinitis, asthma, and things like that. But they are located between the host and environment, such as the skin, the GI tract, respiratory mucosa. And so they have easy contact with external environments and pathogens. They do affect hemostasis, or blood clotting, by vascular and cellular components through platelets, monocytes, and neutrophils, as well as clotting and fibrinolytic factors. So they do secrete a lot of mediators you may be familiar with, like histamine, big one, tryptase, conosoids, chemokines, cytokines, and they do promote blood clotting. So if you have a mold issue and you're exposed to mold and mold toxicity, you are actually setting yourself up for more biofilms and more blood clotting. There's different types of mast cell diseases I don't want to get into. I have a mast cell educational module for that. But it is very common in different parts of the world, not just in the US. It is characterized by epigenetic and genetic alterations, and environmental influence is a big one, being mold can be a big one. Other types of infections and toxins can also contribute to this problem. So there's substances released by activated mast cells, which can affect blood clotting. And I like to just clarify that blood clotting and biofilm formation, they're shared mechanisms of action. So if you have this promotion of blood clots, you're going to have increased risk of biofilms because of the fibrin. So we have histamine, heparin, vasoactive intestinal polypeptide, prostanoids, tryptase and chymase, tissue type plasminogen activator, TPA, and factor 7. So mast cells release histamine. And the interesting part is they can either cause or inhibit thrombosis depending on whether it's acting on resting endothelial cells or on cells pre-activated by other inflammatory stimuli. Tryptase is the same thing. It can have anticoagulant and procoagulant effects, so it's not always going to be procoagulant. So mast cells do generate other growth factors and cytokines too. So there's a whole other mechanism of action of mast cells, even without them being degranulated. So high concentrations in circulation can be achieved. Both clinically significant bleeding and thrombosis can occur. So like I said, it can go either way. But here's another thing. Platelet activation can trigger mast cell activation. So back to platelets we go. It can trigger mast cells. So let's talk again about COVID. Let's say COVID or some other infection that can go trigger iNOS, that can trigger platelet activation, can then indirectly go ahead and stimulate mast cells. So that all of that together can distort hemostasis. Hot topic, fungal infections, fungi mast cell connection. And yes, mast cells are involved in the mechanism of fungal infections. Major problem around the world. Problem is broad spectrum antibiotic use can increase this deficient immune state and make fungi opportunistic. This is what I'm seeing a lot. So people always tell me, I don't have mold in my home. I don't think it's mold in my house. I'm not sure where it's coming from. And honestly, it's probably systemic. You probably already had some, then suppressed your immune system, and then it became pathogenic. It doesn't always have to be exposure in the home at the current moment that you're infected. So here's some common indoor molds listed here. Now, a very common fungi is Candida. It's the most common, colonizing various parts of the body, including the genitourinary tract as well. When your immune system is suppressed, Candida can result in severe invasive diseases. The mast cells activated by this can release IL-8, which can attract neutrophils. So mast cells play a role in the defense against Candida as well. And again, this inflammatory cytokines can be released. We also have something called reactive oxygen species and nitric oxide that are released. And then the mast cells contribute to loss of barrier function, leaky gut, for example, and higher sensitization against food antigens. So then you get a lot of food sensitivities and food allergies because of this. So presence of having Candida in high levels can contribute not only to dysbiosis, that can contribute to inflammation, but also food allergies and food sensitivities. So a method that has gained considerable attention in recent years is measuring the DrMandyDCN level, which is often used as a marker for invasive Candida. It's a 5-carbon sugar alcohol produced by most pathogenic and medically important Candida species, and there's been various methods for measuring it. Blood and urine have been developed since 1979, although different people have different beliefs about it. But there's been a lot of studies that show that too much arabinol found in patients was, in fact, relevant to an infection. So I actually can do this on the NutriEval test. There's a marker called DrMandyDCN that can indicate if there's potential Candida in the body. Aspergillus is the most common fungus group in our environment that can cause a lot of disorders. But people with normal and functioning immune systems can not have symptoms. They could be asymptomatic. So after Candida, Aspergillus can cause the next level of the most infections. So Candida is very, very common, and Aspergillus seems to be the most second common. It's responsible for allergies, mast cell activation, toxicity. It can be invasive. It can provoke allergies by increasing the IgE-mediated response involving mast cells with cytokines, and it can recruit mast cells into this fungal infected tissue, which is why that's a very classic feature of this allergic inflammation. And IL-1 is also found when there's mold, and inflammation can contribute to tissue remodeling, pain, and arachidonic acid cascade and activation, and then you guessed it, hemostasis. I used to do urine testing, not so much anymore because I have found that the urinary levels are not indicative of immune response. So even though it'll tell you how much your body's excreting, it hasn't been really relevant for telling you what's going on in the immune system. So I've switched away from urine testing. So I like the blood testing better. It gives a better indication of what's going on in the immune response. And as you can see here, this person has an IgE-mediated response, which is going to lead to loads of histamine, mast cell activation, and tons of those types of symptoms and food allergies and all those things. So it's important to be able to see. Not that I dislike urine testing, I just feel like this is much more representative of what's going on in the body. E. coli UTIs are very common among patients with IC. In fact, uropathogenic E. coli is the most common cause of UTI. About 80% of infections are. They are formed from multicellular communities known as biofilms. They can be on the surface of catheters, bladder walls, within the bladder itself. So the ability of bacteria to form them is basically important because some people are a little bit more predisposed to that. And it's important in the pathogenesis of human infection. Now, biofilm formation, we're talking about this coagulation pathway. They're related. It involves multiple intrinsic factors, and fibrinogen-induced biofilm. These are the most resistant to antibiotics. So it becomes really hard to treat UTIs when people have these types of biofilms. There's a very interesting process how biofilms are formed. It involves a lot of different factors I don't want to get into. It's a little complicated, not necessary, but understand there is something called an extracellular matrix. That's what really, once the bacteria are attached to the surface from the planktonic form, they can quickly create this matrix, and this makes these infections really, really virulent. Fibrinogen can increase the adherence to bacteria, that they can adhere to the cells, endothelial cells. And fibrinogen that induces this adhesion may enhance the ability to enter the cells and avoid being eliminated by the immune system. Really scary stuff. And it does involve a fibrinogen binding activity that occurs. There's something to be aware of called TMAO, okay, trimethylene N oxide, which can reduce the susceptibility of certain infections like E. coli with multiple antibiotics. It is generated from choline, betaine, and carnitine by gut microbes, and there are foods that are very high in this, such as red meat, eggs, dairy, and saltwater fish. And unfortunately, levels of TMAO increase with age. You can actually get a blood test for TMAO if you want to know if this is a problem, because it is a big problem for the development of cardiovascular disease. And it is generated by the action of gut microbiota from this dietary choline, but even phosphatidylcholine. And a lot of times people take high doses of choline or phosphatidylcholine, or they're eating a lot of like carnivorous diet with all these foods, and they could be actually increasing their TMAO activity, which can then reduce E. coli susceptibility to antibiotics. Interestingly, various constituents in the urine can affect the microbiome of the bladder, and a journal article published in 2022 reported that TMAO can reduce the susceptibility of E. coli to antibiotics, and this is based on what's in the urine. High levels, I said, are associated with cardiovascular disease too, such as, altering cholesterol and bile acid metabolism and activating inflammation and promoting foam cells. But the levels increase with decreasing kidney function. So if someone has, renal impairment or renal disease, or even diabetes can affect your kidneys, and this can actually increase your TMAO levels, and this can increase the risk of UTIs because it does reduce the susceptibility if this stuff is present in the urine, susceptibility of certain bacteria to certain antibiotics. If that's not bad enough, TMAO can induce expression of inflammatory cytokines mediated by NF-kappa beta. Again, the gut microbes that derive or make this can enhance platelet responsiveness and thrombosis. Plasma levels can predict thrombosis risk, so it's important to get your blood checked, especially if you're older, to see what your levels are. A diet that contains a lot of choline or betaine or TMA-producing metabolites or things that produce TMAO can enhance the upregulation of macrophage scavenger receptors linked to atherosclerosis. And unfortunately, a diet rich in carnitine, choline, or even TMAO can reduce reverse cholesterol transport, so it can actually cause increase in cholesterol as well. Let's move on to endometriosis, because this is a hot topic as well. A lot of my patients suffer from this. A study published in 2018 reported that platelets play a crucial role in the development of endometriosis. Women who have endometriosis tend to be in a hypercoagulative state. Endometriosis is defined as the deposition and growth of endometrium-like tissues outside the uterine cavity. It's a common disorder. It affects about 6 to 10% of reproductive age women. Very common. And as a major contributor to pelvic pain and infertility, it is a very high cause of hospitalizations, gynecological hospitalizations. Now, it's always been viewed as a hormonal disease because of estrogen dependence and growth and maintenance of the endometrium as a result of estrogen. In the past 2 decades, it's been more evident that inflammation and coagulation, 2 different things, are involved in this as well. So inflammation activates the coagulation cascade, and coagulation modulates the inflammatory activity, as it does in cardiovascular disease, it does here as well. So because of these activate platelets that play a role in initiating inflammation, we're finding that more women with endometriosis are hypercoagulable. So that may be the link between endometriosis and chronic and biofilm infections. So there's some biomarkers down here that can also that can be checked to see if they're hypercoagulable as well. So you might want to talk to your doctor about that. So PCOS, another one, have shown dysregulated of hemostatic system, so they can also be hypercoagulable. PCOS is characterized by a prothrombic state as reflected by increased PAI activity and fibrinogen. And this is even without signs of dyslipidemia. So they may not have high blood fats, but they are in a pro-inflammatory state. PCOS is the most common endocrine abnormality in premenopausal women, and it does have other characteristics, but the one I want to focus on is the fact that many women are prothrombic. And again, that's been demonstrated by this increased PAI-1 activity. So elevated PAI-1 was associated with insulin resistance characterized by low sex hormone binding globulin, elevated CRP, and high insulin. Sex hormone binding globulin transports testosterone and other hormones in the blood, reducing their metabolic clearance rate and regulates their access to target tissues. Levels are lower when somebody has increased obesity, and the levels can increase when there's weight loss by dieting or other types of interventions. Levels are low when someone's diabetic or they have metabolic syndrome. But anyway, low levels are associated with an increased risk of developing metabolic syndrome or even gestational diabetes or type 2 diabetes, and also cardiovascular issues. There is an inverse correlation between this and fasting glucose, and also C-peptide. So improving blood sugar can improve this as well. Now, here's the thing. Women with PCOS are more prone to developing insulin resistance, and that's seen with high insulin levels, poorly managed blood fats, hypertension, high blood pressure, and obesity. And these are all components of that increase the risk of a lot of different things. But the big thing is low levels of sex hormone binding globulin and high insulin was seen alongside of high PAI1, which makes these people more prone to hypercoagulation because the high insulin, due to insulin resistance, can impair fibrinolysis and can enhance PAI1 secretion. So you can see there's a relationship with even hormones and hormone imbalance and hypercoagulation, and hence the biofilms as well. So there is, again, disturbed fibrinolysis in women with PCOS indicated by high PA1 activity, and this is often associated with variables closely related to insulin resistance. Some results do point to a prothrombic state, as seen in things like hypercoagulation, endothelial dysfunction, platelet dysfunction, and things of that sort. So here's some genetics that goes along with this problem, and I see a lot in clinic, and we can test for. The main one I see is the PAI1 mutation, 4G, 5G, or 4G, 4G deletion. Normal is 5G, 5G. This impairs the ability to convert plasminogen to plasmin and increases the risk of antibiotic-resistant biofilms and infections. Just one copy is enough to impair the ability to convert plasminogen to plasmin. So a lot of questions I ask is, do you have a family history of cardiovascular disease? Do you have a history of chronic infections, ear infections, sinus infections? And men generally have prostatitis, and this population does not respond well to antibiotics for chronic infections. The next one is the factor V Leiden mutation, not seen as often, but still prevalent in some people. It's a point mutation, and it increases the risk of thrombosis, mainly if someone's homozygous, which means they have two copies, and it does exhibit incomplete penetrance, which means some people with the mutation may never develop a thrombotic event. Lp(a). This one is often associated with cardiovascular disease. There's some conflicts in the literature about the role it plays. However, one thing's for sure, Lp(a) binds up tissue plasminogen activator, TPA, and which is made by endothelial tissue to make plasminogen, and without that, we have an increased risk of blood clotting. So genetic variations in the gene can increase Lp(a), but also this increases coronary artery disease, suggesting that Lp(a) is a causal risk factor for coronary artery disease. Lp(a) is the preferential lipoprotein carrier for oxidized phospholipids, and it can be pro-inflammatory. It can affect endothelial function, inflammation, oxidative stress, fibrinolysis, and plaque stability, and this can increase the risk of not only coronary artery disease, but also now we know the link to biofilms. So within my patient population, I've seen quite a bit of patients that have a phenotype associated with the polymorphism of iNOS or NOS2, which often have an upregulation, and this can increase your risk of activated platelets when there's weakness in things such as pro-resolving mediators, which you can get from fish oils. An increase in activated platelets can increase the formation of fibrin. That's because activated platelets secrete coagulation factors and support thrombin and fibrin formation. And these pathways can definitely, these are pathways that are inversely balanced between the formation of a platelet fibrin thrombus. So nitric oxide has different effects inside the body. Again, it plays a role in platelet aggregation, blood flow, neurotransmitters, and other things. But when it's inducible, it can play a stimulation or stimulatory role in platelet activation. And there is an iNOS-dependent nitric oxide production in platelets induced by thrombin. Now here's what's interesting. Homocysteine, which we can also check for on a lab, which I do, can increase platelet activation too, as well. In fact, as much as 5 micromoles per liter elevation homocysteine was associated with a 27% higher risk of venous thrombus. That's pretty significant. And 60% higher risk of venous thrombosis in retrospective studies. Homocysteine can increase platelet stickiness associated with arterial and venous thrombosis, but there's more studies that need to confirm that. Many patients have polymorphisms in an enzyme that increases the risk of high homocysteine, and this is MTHFR C677T. This polymorphism has been shown to result in increased total homocysteine concentration when there's low folate, but also TMG as well. So both of them can help lower homocysteine, but we need to always check to see what the nutrition is and check to see polymorphism. Another gene polymorphism is CBS. If someone is homocysteine in that, this can also raise homocysteine. About 30% of patients will have an event by 20, 50% by 30, and 60% by 40. So this can cause moderately and mild elevated homocysteine, which are often seen as well. Nitric oxide is an important cellular signaling molecule that participates in diverse functions in mammals. It is involved in vasodilation, antiplatelet activity, antioxidant activity, antiproliferative, anti-adhesive. But there's three forms. There's eNOS, nNOS, and iNOS, which I just talked about. iNOS is the main one. It's involved in invading pathogens, but also lipopolysaccharides, viruses, and cytokines. It can combine with superoxide, though, to form peroxynitrite, and this is a potent oxidant and nitrating agent, and this alone can cause a load of oxidative stress and promote DNA damage as well. So it's important to know if you have a polymorphism and an upregulation, because this can be another contributing factor to the problem. So I just talked about all the different things nitric oxide plays a role in, but again, inducible nitric oxide plays that stimulatory role in platelet activation, and there's an iNOS-dependent nitric oxide production in platelets induced by thrombin. Here's a journal article that talks about how activated platelets secrete coagulation factors and support thrombin and fibrin, and clinical studies support a high degree of integration between platelets and coagulation. Homocysteine is a non-structural amino acid formed from methionine, and methionine is converted to homocysteine via SAM and S-adenosyl homocysteine, so both of them, and they release a methyl group, which is used in a lot of methylation reactions, but it can irreversibly be metabolized to cysteine via the transsulfuration pathway, and it also can help make glutathione. It is metabolized via the transsulfuration using a P5P dependent enzyme. P5P is your vitamin B6, and that goes through the CBS, which just talked about earlier, so it's an enzyme. It's very interesting to see how people have definitely mutations in both CBS and THFR, and then they're vitamin B6 deficient, and then they wonder why they have high homocysteine, or maybe they have a low glutathione. Very interesting finding with my population. Elevated homocysteine can be a big problem. It can lead to endothelial dysfunction, increased platelet stickiness associated with arterial and venous thrombosis, increased platelet activation. Risk factor is increased when there's factor V Leiden mutation. It could also increase the risk if there's a CBS deficiency. But other things include B12 and folate deficiency, inborn errors of homocysteine remethylation, and kidney issues and certain medications. Now, the reference range limit is 16, but many studies indicate that's grossly elevated. Many studies indicate grossly elevated levels of 100. So there seems to be a wide range of different symptoms and pathologies associated with homocysteine, but I personally like the optimal range to be between 6 and 8, just because of all the risk factors we see with endothelial dysfunction and vascular disease. So 6 to 8 was what you want. Now, if you start going too low, maybe say there's a CBS upregulation, or maybe there's other reasons why the homocysteine is low, maybe methionine deficiency, or maybe there's oxidative stress. If it's really low, that could indicate that there is oxidative stress, and that could be due to glutathione deficiency. Can be a problem with that as well. So have to stay in that nice tight range of 6 to 8. CBS, another enzyme that I talked about. Cystathionine beta synthase. It's expressed in the liver, pancreas, and kidney and brain. It is B6 dependent. Deficiency can lead to a buildup of homocysteine. It can decrease cysteine levels and increase oxidative stress because it can affect glutathione. It could lead to many implications. So if the P5P responsive type presents with a little bit milder symptoms. Now we know that CBS upregulation though can also be a problem with ammonia. So that's something that I also talk about, but right now we're talking about the deficiency and how it can affect oxidative stress, which can be a problem because oftentimes that can actually indirectly increase how much oxalates your body produces as well. So it's a very complicated process. We really want to make sure we know what we have going on. Now here's something interesting. If someone has a significant CBS deficiency, they can actually have a certain characteristic or look to them. Many have excessive height and limb length and are prone to osteoporosis after childhood. Many have bone deformities. They can be problems with the central nervous system. Many are intellectual, but they may have psychiatric and behavioral problems, especially if they're B6 unresponsive. Without treatment, 90% unresponsive patients will have learning disabilities. There might be some seizures going on. Neurological implications such as seizure and movement disorders can be common, strokes. And then vascularly, they can have thromboembolism, and it's more common than arterial because it can affect any part of the body. So again, CBS deficiency is characterized biochemically by accumulation of homocysteine, decreased synthesis of cystathionine and cysteine, and unusually by increased methionine. However, the classic pattern is not always observed in everybody. MTHFR is a regulating enzyme in folate and homocysteine metabolism, and the most common polymorphism we see is a CT substitution in this 677 position, so C677TT, and there is impaired folate binding and reduced MTHFR activity. It's common in 10 to 12% of Caucasian of Northern European descent, and folate deficiency can cause elevated homocysteine, and the cofactors for this enzyme are riboflavin and niacin. MTHFR donates a methyl group for homocysteine conversion back to methionine. It commits the 5,10 MTHF to homocysteine to methionine formation, as you see here, and polymorphisms can result in reduced enzyme activity, so folate is also required. I can do this test, I do with all my patients whenever possible. It's the NutriEval or the metabolomics. If I see elevated FIGLU, that's a sign of folate deficiency. MMA is a sign of B12 deficiency, because it's needed for MTR, B12 is. And elevation in glutaric acid and isovaleric glycine can tell me that there's a B2 deficiency. So there's a lot of different tests that we can do to see if these enzymes might be needing a little bit more nutritional support to function better. If there's high homocysteine, you want to restrict methionine. Interestingly, methionine restriction is also recommended for cancer. So that's fish, eggs, turkey, bacon, beef, chicken breast, pork, Brazil nuts, if there is high homocysteine. Treatment can be done with high-dose betaine. Betaine is actually found in the Vicon, but you can take a higher dose if there is high homocysteine. B12 folate and B2 supplementation also help in increasing folate in the diet. All right, let's get into some therapeutic strategies. The first one is SPM, specialized pro-resolving mediators. We are evolved to become inflamed, and we do need inflammation to cope with pathogens, predators, physical injuries, but we need a finely tuned inflammatory response, which is vital for defense mechanisms against harmful stimuli of infectious and non-infectious origin. However, our lifestyle and environment have disrupted this natural defense, leading to chronic inflammation, and instead of resolving it, we now face an epidemic of uncontrolled and chronic inflammation, putting ourselves and our patients at increased risk of many diseases. So inflammation resilience is a critical component of cellular resilience. This is what I tell all my patients. So this resolution response is active and highly coordinated. And there's a group of lipid mediators known as specialized pro-resolving mediators, SPMs, and they're critical to our body's ability to return to homeostasis or to bounce back from inflammation. And this discovery provides us with a new way of viewing and understanding inflammation. Now, SPMs are produced in the body from polyunsaturated, long-chain polyunsaturated fatty acids via various steps, and there are several classes of SPM, and they work together to coordinately resolve inflammation. EPA, which you get from fish oil, can give rise to a group of SPMs, and DHA can give rise to another group of resolvents. So there's different kinds. I don't want to get into that too much, but the key is they have beneficial antithrombotic properties, and They consist of lipoxins, resolvins, protectins, and myrisins, and the main receptors are in our immune cells and also in our platelets. So these SBMs are a new class of immunoresolvents that limit acute responses and help clear tissue pathogens, dying cells, and debris. They regulate host responses to bacterial, fungal, and parasitic pathogens, and they promote resolution of non-infectious inflammation and tissue injury, so they can also help after surgery or injury as well. So they're really good because it can inhibit platelet activation and aggregation, and that can help with this whole process of hypercoagulation. They are derived from your polyunsaturated fatty acids, so they do require good enzymatic conversion, which is why we like to take this as a supplement, because sometimes we may not be very good or might need a little bit more support with a supplement, and they are very powerful. Therapeutic strategy, lumbrokinase, also known as Baluki, which is the brand I use. So they come from earthworms, and the earthworms have been used as traditional medicine in China for a long time, and they contain many compounds with medicinal properties and have been administered to treat inflammation, hematological, oxidative, and nerve disease, and earthworms also exhibit fibrinolytic activity. There's different parts of the earthworm that have an enzyme that dissolve fibrin, and ground up earthworm powder has been used as oral administration to support circulatory health and treat blood diseases. It does not cause excessive bleeding, so that's the one good thing about it, and it is promising for dissolving clots, lowering whole blood viscosity, and reducing platelet aggregation. So the oral administration of this is considered as a potent and effective supplement for supporting healthy blood circulation. Therapeutic strategy, royal jelly. It's a highly nutritious natural product, and it's gained recognition for its health-promoting properties. It's a yellowish-white creamy substance that's secreted by the hypopharyngeal and mandibular glands of worker bees, and it serves as the primary nourishment for developing larvae during their initial 3 days, and it's exclusive food for the honeybee queens throughout their lives. Now, it is recognized for its exceptional nutritional value. It consists of protein, lipids, carbs, minerals, amino acids, vitamins, enzymes, and hormones, and lots of amino acids. Vitamins include biotin, riboflavin, thiamine, pantothenic acid, inositol, niacin, peroxidine, vitamin E, potassium, phosphorus, calcium, magnesium, sodium, zinc, chromium, and cadmium. So it's a superfood. And it has a lot of very interesting characteristics as a result of it. But here's what's really cool. It's anti-inflammatory, antioxidant, anti-tumor, anti-aging, antibacterial, and it may inhibit iNOS and COX-2 expression. It can downregulate IL-6, IL-1 beta, TNF-alpha. It can upregulate hemoxygenase 1, and it can scavenge free radicals and may work to maintain redox balance. The fact that it inhibits iNOS is really cool, because if we have an upregulation of that iNOS and platelet activation, this can actually slow that down. Phenols, another therapeutic strategy. As mentioned earlier, there's a range of hemostasis dysfunctions, such as coagulation and changes of blood platelet function, and that's associated with oxidative stress. So a diet rich in fruits and vegetables has a significant influence on this. Various authors have found that fruit and vegetable consumption influence the activity of various elements of hemostasis, such as coagulation proteins, by reducing oxidative stress in the cardiovascular system and inhibiting blood platelet activation. They're not only found in medicinal plants, but also in the edible parts of fruits and vegetables, which form a key part of the diet. And these things include various different things, such as coffee, even coffee and wine, and beverages such as tea, cereals, dry legumes. And they are divided into different groups depending on their structure. So we have flavonoids, phenolic acids, stilbenes, tannins, coumarins, lignans, and curcuminoids. So another way to influence this with a healthy diet. Therapeutic strategy, resveratrol, secondary metabolite produced by some species, mostly found in dark grapes, but also mulberry, blackcurrant, blueberry, cowberry, strawberries, apples. They may inhibit platelet function, reducing cyclooxygenase activity, and inhibit arachidonic acid metabolism into platelets. They can bind fibrinogen and protect it from harmful oxidation and may interact with thrombin, and it does show anticoagulant and antifibrinolytic potential. So the most widely available natural source of resveratrol is the grape, especially the darker version, but again, I told you it's found in other fruits as well. And they say that it may affect primary hemostasis and suppress blood platelet activation, or even secondary hemostasis. So it's worth adding this to your supplement regimen. We add it to our little anti-inflammatory drink. Another natural phenolic compound with antioxidant properties is curcumin, which is being used in natural medicine for thousands of years. It's found in the rhizome extract and often used as a spice known as turmeric. And it is a very strong yellow color that you may see in Indian cuisine, but also other foods such as margarine, mustard, pasta. You can see it used a lot. Chinese medicine uses it for jaundice, liver disease, digestive system, colic, menstrual pain. It has been supportive for wound healing and treating skin discoloration, and it's antiseptic, anti-inflammatory, antioxidant, antiplatelet, anti-cancer. It is recommended for treating eye infections, skin conditions, bites and acne, diseases of the digestive system, diarrhea, and digestion. It can scavenge various intracellular small oxidative molecules and can upregulate expression of glutathione and reduce the production of free radicals. It also has antiplatelet and anticoagulant activity. And they saw that it has antioxidative potential in blood platelets, and because it can also modulate free radicals, it can indirectly affect the coagulation pathway. Curcumin can increase prothrombin time and inhibit the generation of thrombin and the activity of different factors in coagulation. So another really good thing to add to your supplement protocols as well. You can get that in liposomal form in just curcumin so that you're not going to deal with all the oxalates in there. Quercetin is found in a lot of fruits and vegetables. It's also found in tea, red wine, onions, apples, medicinal herbs, capers. It has very high antioxidant activity. It's a mast cell stabilizer. It can scavenge free radicals. It can limit production of free radicals in cells. It can also chelate heavy metals, which is kind of cool, and can break the cascade of free radical reactions. You can get it from food, obviously, but also you can take it as a supplement as well. Quercetin may inhibit LDL oxidation and have a protective effect on nitric oxide function under oxidative stress, but you do need about 6 milligrams per quercetin to inhibit platelets. So it's a pretty high dose, but it can inhibit platelet adhesion to collagen and fibrinogen. Bacillus subtilis, spore-based probiotics, megaspore. My patients all start with HU58. That's your Bacillus subtilis. Another strategy here used, these are spore-based probiotics, remain dormant and are used commercially as competitive exclusion. So they are dormant life forms, and they've been studied for a long time for understanding cellular differentiation. And what we like about them is they are very resilient, and they can withstand stomach acid even. So these gram-positive spore-forming probiotics may be a good alternative because the endospores that encapsulate the strains are resistant to stomach acid, like I just said, and temperature, heat, things like that. Now, there's a study by McFarland in 2017 that found a 42% reduction in metabolic endotoxemia, which is pretty exciting. And they also saw a reduction in inflammatory cytokines, possibly by altering gut microbiome, altering intestinal permeability, so like things such as like IL-12, IL-1 beta, IL-6, IL-8 were seen. So it may have affected the gut, which may have affected the inflammation. So it does have anti-inflammatory, and also TNF-alpha, which I see people who have upregulation in that as well. So that could be a beneficial effect of that. So Lactobacillus rhamnosus is another one. These are other probiotics that can help reduce something known as TMAO. That's another thing that can contribute to atherosclerosis and age-related disease. And plasma levels can be tested, and they're usually higher when there's a lot of carnitine in the diet. So L-carnitine from meat can contribute to high levels of TMAO, but another way TMAO can also be increases with dysbiosis in the gut bacteria. Some people also say too much choline can also contribute to high TMAO. So if you're concerned, you can check your blood. But we found out that Lactobacillus rhamnosus plantarum can improve the gut barrier, and then that can also help reduce TMAO levels. So, so as you understand, different factors such as the gut microbiome, the diet, lifestyle, and genetics play a major role in the development of atherosclerosis and this whole pathology of hypercoagulation. So things like a high fiber diet, you can see on the left over here, active lifestyle, intake of probiotics, increased abundance of beneficial gut bacteria, and short chain fatty acids, as a result, can support tight junctions and protect the intestinal epithelium, as you can see here, and prevent harmful metabolites from entering the circulation. High fat diet, on the other hand, you see on the right, sedentary lifestyle, intestinal disease like Crohn's disease, IBS, and even taking certain drugs like lots of antibiotics and aging, unfortunately, can lead to disruption in the gut microbiome, resulting in higher abundance of pathogens and less short-chain fatty acids. And this can lead to damage to the gut lining, gut epithelium, and the leaky gut allows the translocation of lipopolysaccharides, as you see here, and then TMO as well, or TMO, and this can get into the circulation, cause inflammation, and can lead to plaque. So now you see how this can contribute to plaque formation. Another strategy to use is prebiotics. They're non-digestible dietary products that can be fermented by the gut microflora and stimulate the growth of good bacteria. Prebiotics and probiotics are both able to modulate the gut microbiome, resulting in favorable effects. They have other bioactive compounds too, and they can modulate the good bacteria, increasing the Bacteroides firmicutes ratio, improving the growth of Bacteroides, Lactobacillus, and Bifido. So while you're increasing your prebiotic-containing foods, you want to also reduce your intake of TMAO, such as L-carnitine and choline, high choline-containing foods as well. Another therapeutic strategy is zeolite. Zeolites are porous minerals with high absorbency and ion exchange capacity, and they have a very dense network in their molecular structure. And there's different kinds of zeolite, but the one I like is a natural occurring one, which is called zeolite clinopatolite. I think that's how you say it, but ZC, hard to pronounce that. It is excellent at detoxifying. It's an antioxidant, anti-inflammatory. It's used in many applications, but we're starting to recognize the benefits in humans, and my patients use it. I use it myself. And it can remove harmful substances like heavy metals, ammonia, and other molecules in the gut. So it's often good too because it can actually help not only heal the leaky gut, but improve absorption of your minerals. And that's why I often have people mix it in their Vicon and take it together. So here's a picture that came from a journal about how it can clean up the gut terrain by absorbing and chelating harmful toxic substances, heavy metals, mycotoxins, ammonia, cations, pesticides, can strengthen the intestinal wall, can capture free radicals and reduce oxidative stress, and can remove ammonia. And that's pretty much it. That's the end of my slide. So if you want to learn more about how you can reverse your bladder pain if you think you have a problem with hypercoagulation, please reach out to me. I'm on DrMandyDCN, and you can email me as well. Here are some of my references just to show you how many references were used for this presentation. Here's page 1, page 2 of references, and that's the end of this presentation. Hope you enjoyed that. Thank you.